So good afternoon, everyone. Welcome to Neurology Grand Rounds, and it's a real pleasure to introduce Dr. Gloria von Geldern, who's kind of becoming a Grand Rounds all-star because she was already a faculty participant in a clinical pathologic conference earlier in the year. But it's great to have you here. Thanks for agreeing to give this talk. So Gloria is a Northwest native, northwest of Germany. So she's from Cuxhaven, Germany. And when she finished high school, she really wanted a new experience, so she came to the University of Washington for undergraduate work. So she's really been deep roots as a Husky. After she finished her undergraduate work here, she returned to Germany, where she went to medical school at Universität Leipzig and completed a neurology residency in Heinrich Heine University in Dusseldorf. But she couldn't stay away from Seattle long, and nearly immediately came back to the States to complete a neurology residency here at the University of Washington, where she was a very accomplished resident. She served as chief resident and was recipient of the Alex Spence Award for excellent compassion in clinical care. After she finished her residency, she followed her long-time interest in HIV and neuroimmunology, and she did a fellowship in those topics at first Johns Hopkins and then went to the NIH for a period of time as well. And that's where she really developed some of, or expanded her interest in JC virus and treatment of MS, some of the topics she's going to talk about today. And so she's been here since June of 2014 as assistant professor and works in the MS Center. Thank you, Larry.
Thank you. Yeah, thanks for the introduction. Oh, goodness. Yeah, do that now in case you have no reason later. I don't know. Let me see if I can advance things. I unfortunately have nothing to disclose. If anyone wants to sponsor me, feel free. So I do work in the MS Center, and I want to start with a little bit of sort of coming from that angle from multiple sclerosis, which, as you all know, is a demyelinating disease of the central nervous system that has lots of, or can present with lots of different symptoms. And I like this quote of the National MS Society here at the bottom, that it's an unpredictable and often disabling disease. In terms of pathophysiology, there's inflammation that plays a role, demyelination, axonal loss, and especially the inflammation part is something we thankfully can now treat fairly well. And this is a slide I borrowed and adapted and altered from Dr. Annette Wundes. That shows a little bit the developing, expanding landscape of treatments for multiple sclerosis. I'm not going to go into any of these. That would be another talk altogether, and one that I'm happy to give at some point. But just to show you that there's lots of different treatments, and sometimes it's not so easy to figure out which one to choose. And so how do we choose the right treatment for a patient with MS? There are unfortunately no established guidelines, and it's really an individual discussion with the patient. Disease activity, how aggressive is someone's MS, plays a role, and there's a couple of factors there that are listed that are sort of bad prognostic factors. Patient preference plays a role. There's some of these medications I just showed you on this big overview slide are injectables. Is that something the patient can do? The frequency of how often it's taken, side effects, comorbidities play a role, and then some of these medications have significant risk, and in each individual patient, risk tolerance becomes, and what are their views on the risk of these medications becomes an important issue. Unfortunately, sometimes insurance coverage as well. So that's sort of the background to say that MS treatment, and that's really true for lots of other different treatments, are often weighing risks and benefits. And that is something that I want to talk about. I'm not going to spend a lot of time in this talk talking about the benefits, but I want to make it clear here that, of course, it's wonderful that we have all these different medications, and it's wonderful that we can treat MS so much better than we were able to 30 years ago. But because it is a balance between risks and benefits, I am going to talk about risks, and I'm going to talk in particular about a specific risk, the risk of PML, and you already mentioned that that's something that I've worked with for a while. And it's something that's in people's minds and patients' minds, and also in the even general media, as you can see in some of these headlines here. The dark side of immunotherapy, patients choose death risk. So it's PML really is often the one of the main things we talk about when choosing a treatment in patients with MS. So I'm today, and that's all just background, today I'm just hoping to talk a little bit about biology, epidemiology, and psychology of PML, specifically with a focus on its meaning in MS treatment, but hopefully that'll be also helpful as you see a patient with PML in the hospital that does not have MS, that has other reasons for developing PML. Excuse me. So PML, what is PML? Progressive multifocal leukoencephalopathy is a rare, thankfully, but severe and often life-threatening brain infection. My main focus is on MS, which is a demyelinating disease, and PML is also a demyelinating disease, but due to an infection, a lytic infection of oligodendrocytes with JC virus. And I'm going to go into more details on any of these statements in a little bit. It typically occurs in patients with an impaired cellular immunity, so that's why we sometimes see it in disease-modifying therapies for MS. But there's other conditions that are associated with PML. It was first actually seen in hematologic malignancies in the 50s. In 58 was the first time it was actually, the JC virus was isolated in the brain of a patient and named after the first patient with the initials JC. It then became this big problem in the face of the AIDS epidemic in the 80s. And it's still a big issue in HIV-infected patients. It's an AIDS-defining disease, and as you can see here in patients who are not treated with antiretroviral therapy, it's a pretty common complication and problem. It's also something that not necessarily the neurologist even hears about, but that we see in organ transplant patients and bone marrow transplant patients, and patients who have rheumatologic conditions, lupus, for example. And then that's why where my interest comes in immune modulatory therapies for MS. So let me tell you about this JC virus and what it does. It's a human polyoma virus. That's a DNA virus, and this is a picture of this actually fairly beautiful virus, electron microscopy. It's a fairly simple DNA virus that we probably, this is sort of how does it come into the body and into the brain, that we probably inject as a sort of a respiratory infection that most of us will not even be aware of. Maybe you feel a little bit like a cold. And then we know that it does have a latent phase in the kidney and in the bone marrow. From the kidneys, it can sometimes shed into the urine, and from the bone marrow, it can sometimes shed into the blood. Spread into the urine is actually quite frequent in transplant patients. Viremia in the blood is actually not quite so common. What we don't actually quite know yet is how does it then end up in the brain. It's probably going through the blood, but the exact pathway has not really been proven there. And that is what it looks like when it is in the brain. So you can see here on the left, these black dots are the virus particles that are in an oligodendrocyte. And that leads to a sort of reactive building of these giant bizarre astrocytes. These are two typical findings that we see in patients who unfortunately develop PML. And this is when it goes really wrong. This is a patient that I saw alive and then sadly dead, an HIV-infected patient with PML, and you can very easily see what it can do to the brain. This is an extreme case, but that is a brain eaten away by JC virus. And this is what it looks like under the microscope. You can see here the areas of deviation. This is a myelin stain, and you can see that even on a sort of more general stain, you can see that it's destroying areas of the brain. And then the reactive astrocytes pictured here. And obviously you can see the virus, and this is a lot of virus that you can even really see with hardly any magnification here. So that is what it looks like in the brain. Thankfully, if I see a patient in front of me, I don't always look at brain slides or brain slices. So how do I diagnose someone with PML? That was actually surprisingly not so easy a lot of times for people to figure out and to come to an agreement about, and that's why 2 years or 3 years ago now, the AEN put a consensus statement together to say how do we classify the diagnosis of PML. And so it really is three different parts in the diagnosis. One is the clinical features, one is imaging, and one is proving presence of JC virus in usually in the CSF, in some cases also with a brain biopsy. What does that look like? So the clinical features. And the typical presentation there is often cognitive changes. I had a patient that I saw that first noticed that something was different or wrong because she couldn't read the numbers on her credit card when she was trying to order something over the phone. Aphasia, apraxia is fairly common, and sometimes it's just actually personality changes that a family member notices. Vision changes are also fairly frequently. Hemianopia, I've seen people who have cortical blindness actually from PML. And then seizures. These are all obviously very nonspecific and just depend on where JC virus is destroying the brain. But when we have an MS patient who also has a reason for neurological symptoms, it can be helpful to think about what might be a little bit different from symptoms an MS patient might present with. And so an MS patient might present with optic neuritis or spine symptoms, which are not commonly seen in PML. Fevers, something that you also don't usually see in a presentation of someone with PML. I like this small study here that tries to differentiate between PML and MS and the presenting symptoms, and found that, just like I said, optic neuritis and spinal cord presentations were more common in MS, and altered mental status was more common in PML and really not seen in the other conditions. And then MS, more typically just a one symptom type presentation. Obviously there's a lot of overlap, and sometimes that's hard, but those are sort of some of the clinical characteristics, and it's maybe a little bit hard to read, and I don't want to go into details of this disability scale that I helped develop, but I just want to sort of show what kind of domains we ended up including into this scale. And so visual impairment, like I said, sometimes cortical blindness is a not infrequently seen problem, and then these cognitive issues, apraxia, aphasia. Obviously weakness and the sensory changes in ataxia can be the case too, but that's a little bit harder to differentiate from MS. The other thing I just want to mention in terms of the clinical presentation is that PML often not always, but often presents fairly acutely. So I've had patients who were first thought to have a stroke. So let's sort of think of that more compared to the slower onset that you would typically see in MS. But just the clinical presentation is clearly not enough, and so I said imaging is the second part in diagnosing PML. And the MRI of the brain is usually what we are trying to do, which is sensitive but not specific. And you see these hyper-intense, fairly large sometimes, not always, sometimes a little bit sort of ill-defined borders. T2 hyperintensities, you can also see T1 hypointensities. Sometimes it's sort of along the cortex rather than in the sort of deep white matter. They typically should not have a mass effect and should not show gadolinium enhancement, except in iris, and I'll talk more about that in a moment. But so that is what you would typically see on an MRI, which in a patient who just has lupus or a bone marrow transplant is more easily to tell apart than in a patient with MS. And then the third part of diagnosing PML is as I mentioned, CSF, and you want to send a test for JC virus DNA PCR, so it's different from the antibody test that you sometimes order, and I'll talk more about that in just a moment. But so the PCR detects actual presence of JC virus, and there really should not be any JC virus in the CSF. There was a large study from Sweden that looked at 2,000 MS patients that did not have PML and did not detect JC virus in any of them, which isn't to say that maybe we could find it at some point, but really if there is presence of JC virus, that's concerning. I will mention here that I actually haven't gotten an answer back from the UW lab, but I think the threshold, if I remember correctly, is 1,000 copies per microliter. So sometimes you have to send ultrasensitive PCR, which can be done at the NIH or fairly recently the Quest Focus Lab actually also does a more sensitive PCR with a detection threshold of 10 copies per microliter. So that's important because low copy numbers are fairly frequent, especially in MS patients who develop PML. This is a small sort of retrospective study I did at the NIH looking at patients that had CSF samples sent to the NIH for detection of JC virus, and it found, and it might be a selection bias because probably more difficult to diagnose samples are sent to the NIH compared to some other labs, but in these patients who ended up being positive, 69% of them had low copy numbers, less than 500, so something that would not be detected in our lab here. And only 31% of them had higher copy numbers, and there really wasn't a correlation with any other sort of factors. So really, and I'm not going to go into great details of this, but really the take-home message of this is that even low copy numbers of JC virus in the CSF are important and should be sought after if there is clinical suspicion and MRI suspicion.
Reactions or leukocytosis?
What's that? There often is not leukocytosis. So sometimes there might be a mild phagocytosis of 10 cells, but not necessarily. The problem is that this is, like I said, a reactivation of the virus in the setting of immunodeficiency. So the real issue is that there exactly is no immune response to the virus. So most of the cases there really isn't a elevated white count in the CSF. And I forgot I was supposed to repeat the question. So the question was, is there a leukocytosis in the CSF? And typically not.
Gloria, if you have a patient and the first CSF is negative for evidence of JC virus, do you expect that will go up and a second CSF evaluation might show a higher copy number?
So the question is, in a patient who initially does not have detectable JC virus in the CSF, would I expect that copy number to go up? That's a great question, and the answer is probably. Or at least it's worth repeating because maybe the next time you happen to catch it, so to speak. There's not very many studies that look longitudinally at sort of following these patients. And actually, I did that a little bit with the sort of low copy number study here, where a follow-up CSF was obtained. And the answer is that, at least in the 200 patients I looked at, that in some cases they go up, in some cases they stay low copy number, and in some cases the JC virus disappears. So sometimes it does go up. What I will talk about in a moment is that immune reconstitution syndrome in our iris. In that setting, oftentimes the copy numbers go up. So yes, depending on different factors, the copy numbers might go up, or you might just happen to catch the lower numbers the second time around. And sort of tying into that question, this is an algorithm that was proposed a while ago, actually, in specifically in MS patients where there was concern for PML, and what they are sort of, and a lot of people, I think, do that. When you have an MS patient who is treated with natalizumab in this case, and you're worried about PML, they're recommending suspend dosing. Do an MRI. If the MRI doesn't really show any signs, you can go on. But if the MRI is not really excluding PML, then do the CSF. And if you don't find JC virus, that's your question, but you still worry about it because there's a high clinical suspicion, then repeat it, because sometimes the copy number might go up, and sometimes at least you might get the low copy number. Yes?
Gloria, do you know what the false positive rate is for these low copy numbers?
Yeah, that's a great question too. What is the false positive rate? And so that's incredibly hard to sort of verify, because really the gold standard really is the probably the PCR. I found out of these 200 patients who had low copy numbers, only 10 did not have typical clinical and imaging findings. And so following these 10 with time, all of them developed clinical or MRI findings with time. That doesn't mean that there can't be false positives. I'm sure there can be. No test is positive. But so from what we and other people have looked at, the specificity is thought to be very high. So close to 100%. And maybe if you're not sure, you need to assume that it is a real finding.
I wonder if that translates over to some of our other CSF PCRs.
Does that translate to some of our other PCRs? I don't know. The difficult question with that is that most of these other viruses, so for example VZV or I don't know about HSV, but some other viruses I'm sure are more commonly actually residing in the CNS, whereas JC virus is not thought to be latent in the CNS. So I wonder if you could have a clinically meaningless sort of blip of elevated VZV virus in the CNS or CSF without that meaning an actual infection, whereas I think that might be less likely with JC virus, but I think that's, I don't know how to answer that for sure. Yes?
So I want to be sure, are you saying from your study that with the laboratory technology available to us here in Seattle, we would miss this 60% of the time?
Yes. I am suggesting, so the question was, am I suggesting that, I don't know if 60%, and I'll explain that. So am I suggesting that we might miss the diagnosis of PML quite frequently? So I don't think quite 60% of the time, because like I said, the samples that I looked at were sent to the NIH probably for a reason, probably because there was clinical suspicion and it was hard to diagnose at other institutions. So there's certainly a selection bias. And I think that question of JC virus, and I didn't mention that test in the CSF, might look different in different patient populations. So in HIV-infected patients, for example, the patient I showed you the brain of earlier, copy numbers 100,000, 500,000. Then a detection threshold of 1,000 is completely reasonable and absolutely sufficient. This is really a problem that we see specifically in patients, in MS patients treated with immunomodulatory therapy, and specifically with natalizumab, that they tend to have low copy numbers even if they develop PML. And so I think in that setting, in someone who's immunosuppressed and not an HIV patient, and you have a suspicion, then I would always send it out. And it's very easy actually from here to send it out to Quest Focus Lab or to send it to the NIH. But yes, that's important to keep in mind that the generic test that is done in-house here would in this setting not recognize in probably a large number of patients. That's, like I said, different in other patient populations. Does that make sense? Yeah. All right, any more questions about the CSF studies?
I thought that we can ask the lab to have a detection
So you were, the question is, can we ask the lab for low detection threshold? And yes, we can, and what that does is they send it to Focus. Yes. So if you request the low threshold, sort of more sensitive, ultra-sensitive PCR, they will send it out, and they can easily do that. It's just something you have to request and you have to think about. Exactly.
So do you request it automatically, or do you wait to get a result back?
If I send it out on an MS patient, I would always automatically request that, because you don't want to wait. I think the turnaround time is a week or two, and I wouldn't want to wait. So yes. Again, in an HIV patient, that would look differently. What about a transplant patient? I don't know the answer to that, and I think if I'm pressed for time, I would probably try to get the ultrasensitive right away. So the test that's used here is really probably was not necessarily developed with that purpose of being super sensitive, obviously, and is often used also for urine to look for transient shedding of the virus into urine by transplant medicine and things like that. So if you're looking at CSF, which is harder to get than urine, and where the stakes are higher, I probably would send it for the ultrasensitive PCR. All right, so let's move on. What do we do once we have diagnosed someone with PML? And so that brings us to the chapter of treatment. And unfortunately, the answer right now is that lots of different antiviral strategies that people have looked at have not really been found to be particularly helpful. This is a very nice overview table that looks at lots of different mechanisms of action and different medications that were tried, including this cidofovir, which Dr. Mara did a great study on. Unfortunately, did not show benefit. And the same is true for several others that were hopeful. There's individual case reports that some people feel were helpful in the past, but so far, unfortunately, none of these, and the same is true for this row here, have been proven to be helpful. Mirtazapine had a couple of case reports, and others that did not find the benefit, but no real study showing that. Mefloquine is actually terminated prematurely because there was no benefit. So unfortunately, all these medications that are supposed to stop the JC virus really were not found to be helpful so far. And the treatment, therefore, really is restoring the immune system. That looks different depending on why a patient develops PML. If someone has HIV, get them on antiretrovirals quickly. If someone was treated with natalizumab, an MS medication, get that drug out of the system with plasma exchange. Sometimes that's hard. If someone has a inborn immunodeficiency or is post-bone marrow transplant, sometimes it's almost impossible. But that's really the key at the moment to treatment, is restoring the immune system. There are some sort of strategies that some people have tried in patients who have a more sort of harder to treat immunodeficiency, IL-2, IL-7, can sometimes be helpful to sort of boost the immune system, but again, those were not really studied in bigger actual clinical studies so far. But the answer is restore the immune system. There are some future considerations that I think might be promising. An article from late last year showed that they were able to isolate neutralizing antibodies to JC virus from PML patients, and they're hoping that maybe that's sort of like a passive immunization that can be given to patients. That has not been tried, but that's a possibility. I know that the NIH is working on developing an antisense oligonucleotide that looks very good in initial sort of in vitro data, but we all know that the step to actually humans is a far step sometimes. So maybe in the future there are some better treatments specifically against the virus, but right now it's really getting the immune system to fight the virus. Problem is, what happens when the immune system fights the virus? And I mentioned this as a word before. The immune system then can sometimes cause problems, which we call IRIS, or immune reconstitution syndrome, which is a clinical worsening due to improvement of immune function, which we want, that then leads to worsening clinical symptoms, fever, seizures. So the problem is that the immune system doesn't just attack the virus, but also the brain around it. This happens very frequently in patients with Tysabri and natalizumab treatment, at least 90%. In HIV, it's less common, but also common, probably about 50%. And it occurs usually 3 to 6 weeks after you get the immune system back going, after plasma exchange, after starting antiretrovirals. And that is what it looks like in a patient that I saw who ended up having actually a brain biopsy because of that. You see CD4 T cells, CD8 T cells, and lots of immune reaction that is actually leading to problems. And that's what it looks like on the MRI. So you see contrast enhancement. That's a little bit hard to see here, but sort of this a little blotchy or punctate contrast enhancement. You see enlarged lesions. So this was my patient that initially looked like this. These were her PML lesions, and then after the immune system got better, it looked like this. And sometimes they can even develop a mass effect, which, as you can imagine, can be problematic. What do you do about that? The standard, and that's not really been studied in big studies, but it's really common practice, is to give steroids, glucocorticosteroids, usually about prednisone 1 to 2 milligrams per kilogram per day. And that this is just a very small sort of case study. I think it's actually retrospective. But the bottom line is people do better with steroids typically, and they do better usually with, I thought it said the duration, let's see, here, with a longer treatment too. So the patient that you just saw the MRI images of actually required 9 months of prednisone to get through this. And that's often a fine titration of like allowing the immune system to come back enough to fight the virus, but not so much that it causes more problems. And that's often sort of a looking at them clinically frequently, close clinical surveillance, looking at them with MRI occasionally, though the MRI sometimes lags behind a little bit, and sort of titrating to a point where you can slowly get them off the steroids. Yes?
90% of patients who, have natalizumab and then have plasma exchange develop this. Do you just sometimes prophylactically just start and just see?
Haley, that's a great question. So the question is, do you sometimes just prophylactically start steroids if you know that most of them will develop IRIS? And the answer is difficult. Thankfully, these cases are obviously not super common, but there have been a couple of people, a couple of physicians who've done that, who have, with the diagnosis of PML, also started steroids. I know from a group in Florida that's doing that. Unfortunately, again, these are a smaller case series. Unfortunately, that does not tend to look so good, and I think the reason for that is that it's this fine titration. You don't know when they will really develop IRIS. You don't know how severe it is, and you need the immune system to kick in to sort of deal with the virus to a certain degree. And so I don't think, unfortunately, that will ever really be studied in a real clinical study, but the providers who have, or the physicians who have done that, seem to have more difficulty with that strategy, even though it makes sense. than waiting until you do see problems develop. But the key is really, if you diagnose someone, don't just get the immune system back going, but watch out that they will get in trouble probably. All right, another more recent strategy to deal with iris that is even less tested is Maraviroc, which is a CCR5 antagonist that's used for treatment of HIV, but also has been, or it's FDA approved for that, but it's also been used for graft versus host disease. And what that is, so CCR5 is a receptor or marker that is on several different immune cells. It's on B cells, it's on CD4, on CD8 T cells. And we see that CCR5 cells are a prominent part of the immune reaction in PML iris. So that's a pathology picture here of CCR5 staining. And then this is an interesting case where they did serial CSF of a patient both before developing PML and then after, and then during the phase of iris. And you see here that during the phase of PML, their CCR5 positive cells are not very high, and then with the development of iris, the CCR5 immune cells are positive immune cells are really the mainstay of the immune cells in their CSF. That led to the thought maybe treating that specifically, not just all immune cells with steroids, but specifically these types of immune cells might be helpful. And there was one case from a patient in Italy where that was found to be helpful. To be continued, I guess. It's not clear, but it makes sense, maybe, the strategy. Obviously, steroids are cheaper than Maraviroc. So much for sort of a basic general PML background. The next part I will focus more on specific to MS and the epidemiology in that, but are there any other questions about the sort of diagnosis and treatment of PML?
So what is the likelihood of being able to reverse PML once it's established a good foothold in the brain? Let's say you get through ISIS, can you cure someone?
Iris, but ISIS is bad too.
It does nasty things. Iris came right in.
I actually love that. So the question is, what is the long-term outcome, and can you cure PML? And that's a difficult question. So I didn't include this here as a sort of general PML prognosis, but before we had these MS cases, so in HIV, before we had antiretrovirals, the mortality in the first 6 months was 80%, 85%. I think I have a slide on this actually a little bit later. I should have put it here. People who were then treated with antiretrovirals died about 25% of the time. And the mortality is similar in people with PML that's associated with natalizumab. So about 25% of people die. The remaining people usually at some point stabilize, usually after a couple of months stabilize, don't develop any new symptoms, but sometimes might be left with quite significant disability compared to before. What does actually happen in their brain, though? That was really your question, and that's a great question. Most of the time, if you can get their immune system back to normal, they will be fine and they will control the virus. They will not get rid of it, like you and I don't get rid of this virus if we were to carry it, but it doesn't seem to proliferate in the brain. There are some sort of long-term CSF studies, very few patients, that found occasionally still detectable JC virus in the CSF, but most of the time not. So if they seem clinically stable, then it's not detectable in the CSF. I don't know about the brain because we don't do biopsies, obviously. But it seems like it's controlled, the immune system controls it. The tricky thing is, there was a reason why the immune system wasn't good. And if you have a patient who was transplanted or who has a cancer for which they need immunosuppressive medication, then how do you treat that first problem? How do you treat the cancer? And that is sometimes where you really run into problems. Yes, you can probably, I don't know about cure, but like really control PML by leaving them their immune system, but then maybe their underlying cancer comes back or their underlying problem comes back. In MS, it's also tricky. So they were on a treatment for MS, and you can't put them on that treatment anymore. But there are some medications that probably suppress the immune system less. That would be probably safe to give, and you hope then that they control the disease, the MS, enough. So Copaxone, for example, would be a classic medication that you then put someone on. So I don't know if cure is the right word. These patients, you would be very hesitant to ever suppress the immune system ever again, but a lot of people live a long, long time without showing signs of new brain issues from the PML if they can have an intact immune system. All right, so let's talk about MS and how it pertains to PML. So there are lots of different medications, like I said, that we have for MS, thankfully, today. And some have more of a concern for PML than others. The least concern is Copaxone or glatiramer and the different interferon preparations. There's actually never been a case in any of these. And then I'll go through some of these other medications in more detail in a moment, but I want to mention that some of the medications used off-label for MS also carry a PML risk. Alemtuzumab, the most fairly recently approved medication, or Lemtrada, has not had any cases of PML, but it's not been used that much, so it's really hard to say at this point. There's at least a theoretical risk of PML. Similarly for Abaji or teriflunomide, no PML cases in MS, but some for a similar medication in rheumatoid arthritis or psoriatic arthritis, but at least no cases so far. The two other pill form or oral medications for MS, Gilenya and Tecfidera, unfortunately have had cases of PML. Several, so about 3 that were not on natalizumab before out of about 120,000 patients treated with this medication. And similar numbers for Tecfidera, so updated number now is 4 cases in about 135,000 patients. So that's low frequency, but it's certainly been very much in the media and MS patients' worries and minds. For Tecfidera, it seems that lymphocytopenia might play a role. 3 of these had prolonged severe lymphocytopenia. The most recent one had lymphopenia, but not as severe. Because of that, the prescribing information for this medication was actually changed to say, let's check blood counts more frequently. And it's not really clear what to really do in those situations. We looked at that, or I should say, Megan helped look at that in our center, looking at sort of retrospectively the last 2 years, people who were prescribed Tecfidera or dimethyl fumarate, and did they develop lymphopenia? And it's actually not a small number. So 44% of patients developed some degree of lymphopenia, 13% a severe high-grade lymphopenia of less than 500 lymphocytes. And that occurred anytime between 2 and 27 months, so quite a big range too. And these lower lymphocyte counts were correlated with a higher EDSS, so higher disability, MS disability, higher age, and lower a lymphocyte count before starting this medication. And then what did, and I think they got some numbers reversed here, but what did people do? And again, this was a retrospective study. So looking at the patients who had a very low lymphocyte count, in some cases no change was made, and I think this should actually read 40% rather than 20%. In some cases the provider decreased the dose, and in some cases it was stopped. If it was stopped, what happened? So it seemed that a lot of times the recovery of lymphocytes, and this is just one example of one patient, required many months. So this is 6 months and still ongoing of a initially dose reduced and then discontinued medication, but the lymphocytes seem to take a very long time in those patients who develop lymphopenia. So in summary of this sort of tiny little study, a lot of patients developed lymphopenia, and that's higher numbers that were actually reported in the clinical trials of Tecfidera, 13% severe grade 3 lymphopenia. And the other take-home message, blood count should be monitored throughout the treatment because this lymphopenia can develop early and late, 2 to 27 months in our cohort. And it seemed that maybe older patients with more disability and lower lymphocyte counts to begin with may be at higher risk of developing that, so that might be helpful in counseling patients. And then, unfortunately, recovery of these lymphocytes might take quite a while. What do we do with that? Do we even think that the PML risk was linked to lymphopenia just because a couple of the few patients that developed PML had lymphopenia? Do we then reduce the dose of Tecfidera, discontinue it. If we reduce the dose, is a lower dose effective? Actually, probably not, I should say, from the studies. If we stop it, should we re-challenge the patient? Or is this just one more MS medication that's not a good option for this patient? So this can get quite complicated in trying to find a good treatment regimen for the patient. And the medication where in MS PML is the biggest concern is natalizumab or Tysabri. Probably most of you know that it was approved in 2004 by the FDA for MS. It's a very effective, wonderful medication, and then it was withdrawn shortly thereafter because of the occurrence of PML. It's now back on the market, restricted to a prescriber-controlled program, but the rate of PML, and these are slightly outdated, a couple of months old data, so we had 3 or 4 cases on these previous oral medication and 120,000 patients exposed to the medication, and in natalizumab it's 540 for about the same number of patients. So the risk is really much, much higher in natalizumab. And I'm going to talk about why I think that might be. But so there seems to be a specific concern with this medication, but a general concern with all these other immunosuppressive medications. Natalizumab or Tysabri, how does it work? It inhibits leukocyte adhesion to the endothelium. So you can see here the endothelium and the leukocytes can't adhere, and by that it stops T cells and monocytes from entering the CNS. And so decreased immunosurveillance probably plays a role. The other thing that I think might not be irrelevant is that natalizumab also mobilizes lymphocyte precursor CD34 positive cells from the bone marrow. And I told you before, a long time ago, that JC virus hangs out in the bone marrow, and it actually hangs out in the CD34 positive cells. So probably that activation from the bone marrow might play a role in the development of PML. And more information about the immune surveillance. So it actually changes the T and B cells in the CSF quite dramatically compared to the blood. I'll actually go to the next slide because it shows this more impressively, I think. So in the blood, patients, MS patients treated with natalizumab really have a fairly normal CD4-CD8 ratio, but in the CSF, this is a normal MS patient, and then this is one treated with natalizumab. The CD4-CD8 ratio looks like this patient has HIV, so it's a fairly dramatic decrease in the CD4 count in the CSF. So probably that plays a big role too, because we know that HIV patients obviously are at risk of PML as well. And this is what I mentioned before in terms of prognosis. So the mortality is an important piece. It's a disease that unfortunately in HIV, but also in natalizumab, can lead to a high percentage of mortality. And this is a little bit hard to read, but these are Karnofsky scores, so disability or not disability, ability to be independent scores that in people with PML, even months after the diagnosis, are significantly lower than before. I mean, obviously some of these died, but even the survivors might have worsened disability, which is relevant to people's lives. So and the remainder of this section here is really going to focus on natalizumab and PML, because as I showed you, that is the part where in MS treatment the concern of PML is the greatest. So what are risk factors of developing PML in patients treated with natalizumab? And everyone's interested in that because it's such an effective medication, we don't completely want to not use it. So there's 3 factors. One is a test called JCV Antibody Test. If you have that positive, you have a higher risk of PML. Ever having received immunosuppressive therapy increases risk, and how long you've been on Tysabri increases your risk. And so I'll start with the last part, how long you've been on Tysabri. So this is a nice curve that shows that people who were treated with Tysabri for about a year, 1.5 years, 2 years, have an increasing risk. It seems to level out after that, maybe even decrease, even though the numbers that are sort of treated for several years are lower. But it seems that somewhere around 2 years and less seems to be a lesser risk than the other direction. But time of treatment seems to play a role. And then this is sort of a more detailed fleshing out of those 3 points that I mentioned. So the duration, this is just breaking it down between less than 2 years and more than 2 years, prior immunosuppressant use, and then whether someone has JC virus antibodies or not, gives you quite different risk. 1 in 89 versus 1 in 10,000 can be obviously make a big difference. So the JC virus antibody test, I think it's important, and I know Dr. Wundes has said that in her recent talk over the summer, to tell that apart from the PCR test. So those are very different. This is a test in the blood that tells us about risk. That's not actually detecting virus, but just showing immune response that indicates maybe presence of previous infection, which is very different from PCR in the CSF. So the JC virus antibody test is a two-step assay that's also done at Focus Lab, which is actually sort of done for free by the company who sells natalizumab, because they want people to still take their medication, I guess. And for this, it's important that it does have false negatives, probably at least 2.5%, and that someone who is negative on this test doesn't always stay negative. So there's a 5 to 10% seroconversion rate per year. In other words, if you're treating someone with natalizumab with Tysabri, you still need to keep monitoring them. Just because they had a JC virus antibody negative test at some point does not mean that they will in the future. The other thing that's important to know is that a lot of people, healthy people, have JC virus antibodies in their blood. So it's a large percentage. This is a study from the US, this is from Switzerland. Both are similar, that with increasing age, more and more people have this JC virus antibody in their blood, and it seems to be around 40, 50, 60% of people, healthy people, these are blood donors, have JC virus antibodies in their blood. So you might exclude a large number of MS patients from treatment because a lot of people have this antibody. To make it more complicated, there is now also available an index. I think index is not a very great word that they chose, but it's really a titer that looks at the ELISA result and tells you how high this antibody is, or how much of that antibody is present. And a lower titer or a lower index is associated with a lower risk, and a higher with a higher risk. So that can be quite a difference, and quite relevant if you see, and these are sort of updated numbers from last year. Why is 2015 already last year? But between 0.6 in 1,000 versus 10 in 1,000 who develop PML in this setting. So a higher index is a higher risk, is the bottom line for this. And this has only been studied in people who were not on immunosuppressants before. Does that mean someone who doesn't have this antibody, who is JC virus antibody negative, does not have a risk of PML? Unfortunately, it does not, of course. 2 out of 240 patients in this study were JC virus antibody negative. And unfortunately, we had a case in our own clinic. One of my colleagues' patients who, I think you're here, who developed PML after only 2 weeks before having a negative JC virus antibody. So just because someone is JC virus antibody negative, it makes the risk less, but it doesn't mean that you can stop worrying about PML. That's unfortunately the bottom line. She then, at the time of confirming her diagnosis of PML, was JC virus antibody positive, but that is just to show that it's not a guarantee, unfortunately. There is a false negative rate of this test, and people also do seroconvert. And if you're really worried, then don't let a JC virus antibody negativity dissuade you from that worry. Yeah, very unfortunate case. Other potential markers to help in this already fairly complicated risk assessment were not really found to be very helpful. But one thing that seems to be helpful is an increase in this titer or index. It seems to be associated with a higher risk, and it's not other virus titers. So it's really the JC virus antibody titer. If it goes higher, that might indicate that something is going on. And then obviously that is usually done in people where there's already some suspicion. You can actually send the antibody in CSF too and calculate an index between the CSF and the blood, and if that's high, then you're very likely to be dealing with PML soon or already. So we have this very, I feel like I talked for 5-10 minutes now about this risk stratification, how to how to figure out what someone's risk is, does that even help us? I thought this was an interesting editorial from Olaf Stuve, who some of you still remember, who said, well, this test has been available since 2010, and this was written in 2014. It seems like the incidence has not changed. So is this even helping us, that we know of this antibody and risk and all that? What are the reasons? Is it because it's hard to stop Tysabri? Is it hard to stop natalizumab because people get rebound and they're on this medication for a reason, because it's effective? Is it that there's, like I said, seroconversion, false negative tests? Is it too soon to see this effect after 4 years? Or is it that patients maybe are willing to take the risk? And I think that's a very interesting question. We can sort of figure this out from a physician perspective all that we want, but is that something that even matters for patients? So let me lastly, for the last few minutes, and I'll try to be quick, talk about the psychology of PML risk assessment, because I think it's very interesting, and I think it applies to other fields of medicine and neurology as well, not just to treating an MS patient. So this is a very interesting small study from Germany that looked at different centers in Germany and questioned patients and neurologists treating MS patients with Tysabri, and these were all on Tysabri in terms of patients. It was very interesting, I thought, that 80% of patients were willing to take a higher risk, 1 in 100 or 1 in 10 of PML, but only 50% of the physicians. So the disconnect here is at the 1 in a 10 risk. Hardly any of the physicians here in black were willing to take that high of a risk, but a large number, that's like 34% of patients were willing to take a 1 in a 10 risk of developing PML. Why is that? So the other thing they asked patients was, do you think MS is malignant? Do you think MS is bad? And what do you think your 1 year risk of developing a big walking problem, of being able to walk less than 300 feet without being treated with natalizumab, what do you think how high your risk is of that? And you can see here that the patients thought MS was worse than the physicians, and they thought they would have trouble walking much more than the physicians did. And that's why they were willing to continue Tysabri much more than the physicians were. So I think it's interesting, and that comes back to the very beginning. It's a balance of risk and benefits, and we sort of should find out what matters to our patients, and if we want to really counsel them. What is then the right risk perception? And what factors influence risk perception? Are the demographic factors, psychological factors? Is it just understanding, just the medical knowledge? There is not a lot of or there haven't been a lot of studies on that, unfortunately. There's a few. So this is a study not in MS patients, but in general, that showed that maybe demographic factors can play a role in how we perceive risk in general. African Americans were more likely to tolerate a high risk than Caucasians in this study, men more than women, and people who had a higher education, interestingly, were more willing to take a high risk than people with a lower education. So no college. What's that? This was in general sort of risky medical treatments. So this was medical treatments, but not specific to MS. Age did not correlate in this study. And then this is a study more specific where the PML risk was discussed with MS patients, but this was a hypothetical scenario. They were not necessarily treated with Tysabri, and it was not the real numbers that were given to them. I don't know why it was done in that way, but and there was really no association seen between different demographic characteristics, but they found that people who had a high disability or self-reported disability from their MS, so this is higher disability, were willing to take a higher risk of developing PML with a potential hypothetical treatment. That's sort of similar to what I talked about before. And psychological factors, so there's a couple of studies, again not in this patient group, but that show that people who have less psychological distress, this is in PTSD studies for example, were willing to take higher risk. But then there was at least 2 studies that found that depression, higher depression was associated with higher risk taking in medical setting, and the question is that because they felt like they had nothing to lose? I don't know. And then this is hard to explain, but the perception of what this risky intervention might do to the things that distress them was also an important factor. This had not been studied in PML or MS. And yes?
This was, these studies, questions were posed to the patients.
Mm-hmm.
Were they balancing the risk question with the chance of a cure?
That's a great question. Unfortunately, that was not done. It was always sort of, it wasn't posed towards the percentage of cure, but it was just said if this treatment could help you sort of this non-specific could help you, would you be willing to take a risk of a serious complication? So yeah, very, very difficult, and I wish that was done in a more sort of real life setting rather than these hypothetical, not very specific questions. So that's a good question. And then the last thing that has been looked at in MS in a European study was medical knowledge, and they sort of tried to see if people if there was a difference between what their anxiety or depression level or other demographic factors were in terms of how much they could quote facts about different treatments and their risks. And what they found was, and these are pretty detailed medical knowledge questions about MS, and they found that people who were younger tended to have a better understanding of these sort of factors of how effective and risky these treatments were, and people who had higher education, not surprisingly, were as well. And then there seems to be a point where people who did not have relapsing MS seem to be doing better. But so maybe some factors that influence how much people knew about their MS. But I think overall the bottom line is this is a very, very short section because there hasn't been enough study on this, and we're doing one part to sort of look into that more now. So this is a online survey that we're currently doing at the MS Center. That's an international collaboration that's looking at decision making and medical knowledge about these factors of how effective are they and how risky are they. And in our population that we can then compare with people in Europe actually. And we're sort of trying to look at anxiety, depression, and cognitive abilities as influence in risk perception as well. But these are, stay tuned, more soon underway studies currently. And then in the last second, because I'm going much longer than I thought, a shameless plug about a PML registry I'm involved with, because as you see there, PML is affecting different diseases, underlying diseases in different parts of medicine. This is a way to collect clinical data on PML patients and to understand the underlying diseases and demographic and sort of prognostic factors better, because really it's not a reportable disease, and unfortunately the knowledge that we have about mortality and things like that is fairly limited. So that's currently in development, is essentially up and running, and it's developed between different institutions in different fields: oncology, rheumatology, transplant medicine, and of course neurology. With that, I want to close with this picture of our wonderful MS Center team, where we have rehab psychologists and pharmacists and neurologists and lots of different people working together. And I'm open for questions in the remaining 1.5 seconds. Anything anyone didn't get a chance during the talk to
This is kind of a
ask?
practical question.
Yes.
I think most people think of PCR being ultra sensitive already. So the tests done at the NIH, I mean, do they have advanced detection methods, or do they just cycle the reaction more times?
They just cycle it more and
so
dilute.
It's pretty simple
Yeah.
to do.
I don't know exactly what the method is here and why it's
So there's really not
it's
more
not
work for the lab.
it's not magic. I actually tried to reach out to the lab before this talk to talk to them, because I usually just send it away and don't even discuss this in more detail. So I don't know why they're not doing that. But like I said, NIH is not the absolute only place who does it. There's commercial labs too that do it. So I don't know why that's not done. It's done at the Salt Lake Union Virology Lab, and I don't know why they're doing it like that.
Yeah, I was just going to comment because John brought up the specificity of such a other viral PCR studies in CSF, and at least for HSV, it's 98% sensitive and 96% specific, and that's from biopsy-proven HSV.
So that's pretty good,
that's
and
pretty good.
that's probably similar to this. Yeah. Thank you for supplying those numbers. Yes.
So, Gloria, very nice talk and incredibly relevant, not just to MS
Exactly.
in this particular situation, but to every neurologist who has to realize that we're populated by a bunch of things that we didn't have as original equipment in the brain, can be problematic. And I suspect as we live longer and more effective treatments for disease, those things could potentially be problems. All that said, it's very clear that the frequency of JC virus in the brain is high. But the incidence of PML is still extremely low.
Correct.
So people have talked about, and I'm here on very thin knowledge base, different promoter sequences in the JC virus of patients that have PML. And I wondered if that might give you a more precise tool to decide who could take helpful drugs.
I love that question. That's a fantastic question. The question is, different, you said promoter sequences, but why, if the presence of JC virus is fairly common, do we not see PML more? And so I went over this quickly, but this is the DNA or the backbone of JC virus, and there's a conserved structure, and then there's a area here that's coding for the VP1 region, which is the structure that can look different between different patients or different JC viruses. And we do know, and actually the PCR at NIH can detect different quasi-species that have different sequences in this area. There is one that is more commonly found in people who don't develop PML in the kidney and so forth. And then there's one strain found that has a different VP1 region that is commonly found in PML. The tricky thing is that people can have both, and that sometimes, and it seems like usually the immune system controls them both just fine, and that if you look at even the fairly rare viremia where you find virus in the blood, you might have both in parallel, or you might just have one or the other. But you're right, if we detect the PML causing variant, then that's more concerning, and that's something that if we do detect virus before finding it in the CSF in the blood, that then that shows this PML specific VP1 variant, then that's very concerning. And you're absolutely right. That is one test that can be done. The problem is that we don't often find the virus in the blood or in the urine, or not reliably at least. There was a recent study from like 2 months ago that actually looked at PML brains and found that more specifically different promoter and different DNA sequences, that there seems to be several different species that can cause PML. But yes, that's something that might hopefully in the future give us more information. That's a good question. Yes, Dr. Bird.
I was really fascinated by the result from that patient-doctor comparison about how they thought about MS. And there was a huge disconnect between the patients and the neurologists in terms of how they viewed MS as a serious disease or not, and as a disease where they're going to be very disabled within a year. There were big discrepancies here. It's either that neurologists are too cavalier, or more likely, we don't do a good job explaining MS to the patients when they're initially given the diagnosis, what the disease is, what the risks are for disability. I mean, 40% of them thought they would not be walking in a year. That was hugely different from what the neurologists thought. That's part of the reason they're willing to take a very high risk for a dangerous medication, is because of their fear of the disease they have.
I completely agree.
That's a fascinating issue that I think neurologists need to give more thought to.
I completely agree that that's very interesting. So the question or the comment was this huge disconnect between patients and physicians and how bad they think MS is and what the prognosis of disability is. And you're absolutely right. And I think one answer is we need to educate patients more. And I had several patients. Because I'm the newest neurologist in our clinic. See a lot of new patients and diagnose a lot of patients with MS every week. And I frequently hear, okay, my life is over now. I should just die. I will be in a wheelchair next year. And it's hard because there's a lot of different things we need to talk about when someone gets diagnosed with MS. But the same is true for other neurologic conditions. But I think it's really, really important to try to counsel them as much as we can about prognosis and what it looks like to have MS today. The challenge with that is that that's sometimes really hard to predict, and that's why I showed this very first slide of this chaotic picture, and it's a very unpredictable disease, and that makes it so hard. And I wonder if sometimes we also underestimate how the impact of a problem is for a patient, and maybe we are sometimes too cavalier and think, oh, you're just fatigued, well, we'll deal with that. No, that's actually really a problem for me. And that sometimes maybe that goes along with the importance of palliative care, not that I'm assuming these patients are dying, but that we need to work on helping them with their symptoms much more than we sometimes are doing. And I think in terms of the educating them more, there's efforts to do that. We do have a patient seminar once a month in our center, and other places are doing that too. The group that I'm starting to collaborate with in Europe is actually developing sort of online trainings for patients to help them get a better understanding, not just about the medications, but about the disease as well. But it's hard, and it's hard to do that in such an unpredictable disease.
Gloria, you'd be doing me a huge favor if you turned around and looked at Christina Mara's question.
Are people with natalizumab-associated PML viremic? HIV patients are not, and the answer is natalizumab-associated PML patients are also not viremic. Might that suggest that JC virus is latent in the brain? And that's a great question. Possibly. I'm not entirely sure if just the fact that they're not viremic means that, because maybe the viremia was before they developed PML. The reason why I'm not sure that that natalizumab experience suggests that is that one point about natalizumab that I tried to make is that it is pushing immune cells out from the bone marrow where we know JC virus is latent. So it's possible that that then gets them into the brain, but I don't know. I think we still don't know if it's latent in the brain. That's the bottom line.
I know for sure that they can occasionally detect JC virus in completely normal brain.
Absolutely.
That I know for sure.
Yeah, especially in the urine, but also in the blood. Correct.
And in the brain.
And in the brain. But that is it latent there? We don't know that.
Yeah, I mean,
Yeah.
I don't know what the word latent means, but if you find it in the brain, to me that's latent in the brain.
I think latent to me means that it's there over longer periods of time. But I don't know. It's possible. It's very possible. All right. I'm sorry we went over. Any other questions? All right.